Thank you. Does this mic work, or should I speak in this one? Is this just for recording? Can you hear me in this one? No? Okay. Two mics. Thank you for inviting me here today, and thank you for that introduction. I'm going to start off with a brief background, kind of give you a sense of what is a nudge unit, how we formed it here at Penn, and then I'm going to spend most of the time talking about examples, things that we've done, how we've applied different nudges in various contexts of healthcare. Feel free to jump in with questions as we go along the way. So I just like to start out with this, which is that human behavior is the final common pathway for the application of nearly every advance in medicine. No matter how effective a medication, how protective a vaccine, or how targeted we can get a therapy to be, really two things have to happen for it to translate into any benefit for patients. And that involves the dynamic between clinicians and patients. A clinician has to recognize that a patient meets criteria for a test or therapy and recommend or prescribe that, and a patient has to both understand and accept it as well as adhere to it after they do that. If neither of those things happen, a physician or a clinician doesn't prescribe it and a patient doesn't adhere to it, there's obviously going to be no benefit for patients. Unfortunately, that dynamic breaks down a lot. And sometimes we do too much. About a third of healthcare spending, as many of you know, is thought to be unnecessary, wasteful, redundant. But then a lot of times we don't do enough. There are a lot of evidence-based therapies that take years to translate into practice, or even after years are often not offered. We know things can reduce mortality, readmissions, but patients leave the hospital never even being told about them. Over the last decade, there have been two technology platforms that allow us to actually get a better understanding of these decisions and allows us to intervene. The first is electronic health records. So a decade ago, 1 in 5 health systems and doctors was using this, and now it's over 90%. And so now all of the things that used to happen on pen and paper or through oral communication is now happening and being funneled through this electronic portal. And so we can actually see that. We can look at the variations and understand that. But there are a lot of choices and information in there that hasn't been well tested. We can also use this to intervene by changing those choices and the way information is framed. From the patient perspective, mobile devices have really proliferated. More than 70% of Americans in the United States now carry a smartphone everywhere that they go. This is something that most people won't leave home without. Like, I could forget my wallet and probably borrow $5 from someone, or I can use Apple Pay now in the cafeteria downstairs. But if I forgot my phone, I wouldn't know what room this talk was in. I wouldn't be able to communicate with people. It's something I would go back and get. And because we're so tied to these things, we can use them to actually monitor people's activity patterns and use them as a communication tool to be able to communicate with patients in real time. Even in patients of lower socioeconomic status, more than 50% now have a smartphone and carry it everywhere that they go. Over the same decade, the science of motivation, how we actually get people to change behaviors, has evolved. We used to focus most interventions on solely on information. This is the idea that people are unaware, and that if we just inform them that smoking causes cancer, that exercise is good for them, or they should take their medications after having a heart attack, that they'll do those things. But we know that this is not true. It's obviously necessary, but often it's not enough to motivate people to change their behaviors. So many people have moved towards using incentives. If you have health insurance or in some type of insurance plan, you're in an economic incentive plan, whether you know it or not. But most of this is designed around this idea of standard economics, which is that people are perfectly rational. They can understand all the probabilities of making certain decisions. They can understand how the decisions today impact their long-term health and so on. But we know that people don't do that. Instead, people are irrational, but in a predictable way and from a common set of decision errors. And so that's where behavioral economics comes in. It understands that people act irrationally, and rather than focusing solely on incentives, focuses more on the design of information, the way we offer choices, and if we do offer an incentive, how is that incentive framed, how is it delivered, and how do people receive it? And that's where this idea of nudges comes in. So nudges are subtle changes to the environment or choice architecture that can have a huge impact on people's behavior. It's meant to remind, guide, or motivate our decisions. So some examples might be setting the default to the preferred option. This is the path of least resistance, essentially what happens if you don't make a decision. Prompting someone to make an active choice now around decision rather than waiting for them to realize they should make that choice. And then framing information, either through peer comparisons or through price transparency. And I'll show you how we have used all of these different approaches in healthcare settings. So it's important to know that nudges are prevalent already. You've probably all been exposed to these and are exposed to these at a daily basis. Here are 3 examples that I would venture to guess many of you have been exposed to. So the first is from the airlines industry. So let's say you're taking a trip, you've chosen your flight, you picked out your seat, you punched in your credit card number, you go to hit pay, and it tells you, oh, you can't purchase your ticket because you didn't make this one decision. And that is, do you want to buy trip insurance? Every airline requires you to choose if you want trip insurance. You have to actually say no if you don't want it, or say yes and pay extra for it. And the airlines do this because they know that by forcing you to make this active decision, you're more likely to buy trip insurance, when in most cases, it's probably not worth it. It's hard to redeem. Most flights land on time. And if they don't, you need things like a doctor's note to try to get your money back on this. But they add all kinds of things in here. So I don't know if you can see this, but they'll say it's highly recommended. They'll give you 4 reasons what you can get from trip insurance. And then there's this arbitrary statement, it says buy travel insurance. It can protect you against trip cancellation costs. Arbitrary statement, but then it says USA Today, May 2016. And just having like a credible source and a date, people put stock into that. And so a lot of people buy trip insurance when they shouldn't. The next one is from Amazon, or retail more broadly. So let's say you're buying a pair of headphones. You've picked out the ones you like. Maybe they're Bluetooth or wireless. And then you're going to pay for them, and it says, would you like a carrying case to carry those headphones on the flight that you're about to go on? And they've looked and they've seen other people who have bought these headphones, often buy these carrying cases. Oftentimes they'll give you a discount. If you buy it now, you can get $1 off. If you buy it later, you've got to pay full price. And so they're nudging you to buy more of their goods or services. And the third is from Netflix. How many people, has anyone seen Breaking Bad? So a bunch of people have seen Breaking Bad, it sounds like. So as people probably who have seen it know, this is a very addicting show. And if it wasn't addicting enough, Netflix introduced changes to default options to make it even more addicting. So the first thing that they did was they started to show you kind of a sneak preview, just a couple of sentences, what's going to happen. The first episode ends in a cliffhanger, and it kind of tells you what's going to happen. But then about a year ago, they started introducing this, which is that after some certain amount of time, the next episode will automatically play. So it used to be 30 seconds. Now it's down to like 15 or 12 seconds. I can't even stop it. It just goes to the next episode now. So you could watch episode 1, fall asleep, wake up on episode 4, be none the wiser, because this thing will just keep going. And the point here is that Netflix has realized that if by doing this, they're getting people to binge watch. Just watch a bunch of shows in a row. And if you like to binge watch, you probably like Netflix, because the entire season is available at one time, which is completely different than trying to watch something on regular TV. And so this is really good to get people hooked on Netflix. And they've tested this in markets and now rolled it out more broadly and have been making changes over time to make it more addicting. So 3 examples. I'm sure you can think of a bunch of others from experiences that you've had. But the main challenge here is that we think it's probably okay for people to decide, do they want trip insurance? Should I buy this carrying case? Should I watch the next episode of Breaking Bad? That's really up to most people, and they can make a decision around that. But healthcare is much more complex. When these are often conversations between clinicians and patients. If you take something like breast cancer screening, the guidelines for breast cancer screening have changed 3 times in the last decade. And so many patients may not feel like they have the appropriate knowledge or ability to make these decisions on their own. And because nudges can be very influential, we don't want to nudge people in the wrong direction without having an opportunity to think about how we should do this in the right way. So nudge units are meant to address this. These are behavioral design teams that take a systematic approach to thinking about when to use nudges, how we can use them to align with our decisions and the goals of all of the stakeholders. The first nudge unit was actually launched in the United Kingdom. This was an initiative launched by Prime Minister David Cameron, and the idea here was that they were going to spend 2 years seeing if they could improve the lives of the United Kingdom citizens. And if they did, great. If they didn't, it was written in there that the team would be disbanded. But very quickly, they had a bunch of small, really subtle interventions that had huge impact for the country. So one example is making the government more efficient by sending letters to people telling them how their neighbors pay their taxes on time, more citizens pay their taxes on time. So the government got quicker revenue there. They were able to get more citizens to be consent to organ donation, increase donations to charitable contributions, and so on. There's a list of like 100 of these things now. And these types of nudge units have spread all over the world. So each of these is a nudge unit. The pink ones are within governments. The green ones are outside of governments, mostly like financial organizations like the International Monetary Fund. And then the blue ones are groups of countries that have gotten together, their governments, and have said, we're going to launch a nudge unit for our groups of government, for our countries. It wasn't until 2016 that we launched the Penn Medicine Nudge Unit, which was added to the map, which was the world's first behavioral design team embedded within the operations of a health system. This is really a collaboration between two existing centers. So the Center for Health Incentives and Behavioral Economics, run by Kevin Volpe, and the Center for Healthcare Innovation, run by David Ash and Roy Rosen. And the idea was to bridge kind of the rigorous research and the scientific knowledge generated by CHIBE with the pragmatic implementation happening rapidly in the health system that the Innovation Center does. Since 2016, we've launched over 40 projects, worked with more than 11 specialties, some of those listed here, raised a few $1 million in grant funding, $2.5 million in the last year, and have grown the team from 3 people to 20. And we get about 1.5 of those 20 people are funded by the health system. The other 18.5 are funded through grants. So we get some funding to help build infrastructure, and then the rest of it is worked up through these grant mechanisms. Now that being said, we do leverage a lot of the existing infrastructure through these two centers. Like we work a lot with the communication designers and software developers at the Innovation Center. We work with some of the expertise in designing evaluations at CHIBE. When we think about how to choose nudges, we typically look for things that fit into several buckets. One is it's got to be appropriate for a nudge. Not everything can or should be nudged. The second is we want to be able to scale it through technology. So mainly the two platforms I mentioned, the electronic health records or mobile devices. So we can test something in a couple of clinics or a couple of hospital floors, and if it works, roll it out more broadly throughout our health system and potentially to other health systems. And then we're looking for things that are going to have a huge impact on healthcare delivery, not things that have like a couple of percentage point changes. We're looking for areas where we're doing really poorly and we can really move the needle. To do this, we've developed a steering committee that's comprised of leadership in clinical care, information technology, and expertise in behavioral economics. And the idea is that this steering committee vets all of those 40 projects, lets us know if there's already something going on or lessons we should take into account. We will have innovation tournaments where we'll let anyone from the front lines of care submit ideas, and we'll take 100 ideas and vet them down to the top 5. And this committee will help us do that. But they'll also help us to open up doors. So when we have something and we want to implement a change in Epic, they'll help us to prioritize that within IT, figure out the right person to talk to. Our ideas generally come from 3 areas, either leadership themselves, mostly from frontline clinicians who are submitting ideas either through these innovation tournaments or they're just reaching out through our website or emailing me. And then our group itself, after having all of these discussions, will come up with ideas to implement nudges. Any questions on the structure or how the nudge unit was formed before I go into the examples? Okay, great. So the first thing I always like to start off with is the fact that what most people don't realize is we're already being nudged and we don't know it. When we talk about nudging, a lot of clinicians will say, you know, I spent a decade of training, I've spent many years in practice, I don't want someone else influencing my decisions or the way that I interact with patients. And what we have to enlighten them to or make them aware of is that actually this is already happening, but in many cases, people haven't paid attention to it, and it's probably actually nudging you in the wrong direction. And so here's an example. For years, Penn Medicine was the worst in the region in generic prescribing, worse than Temple, worse than Drexel, worse than all of the other folks in the region, so much so that we were getting fined from the largest insurance company here. This clinician is prescribing Coreg, a brand name beta blocker. They may have typed in Coreg because it's shorter, easier to remember than carvedilol. They may have typed it in because the patient said, hey, I need a prescription for Coreg. Whatever the reason is, like a regular search function, if you were to type in Coreg into Google, it would find Coreg, and that's what Epic is doing here. But by doing that, it's actually nudging you to prescribe the brand name prescription because it's listed first, and then it shows the generic options below that. The name is actually even cut off. And clinicians are probably, you have a couple of seconds to do this because you're putting in 6 or 7 or more of these medications at once, especially for new patients. So you're just going through. The path of least resistance is just to pick something at the top of the list and move forward. But this is inadvertently nudging us to prescribe the brand name prescription, which for most drugs is the same as the generic, but oftentimes much more expensive. And Penn was the worst at this in the region. They went to all the clinicians who were outliers. There were grand rounds about this, but really didn't move the needle. And so internal medicine actually went ahead and changed this so it would only display the generic. So this was called a display default. And we compared this to family medicine who didn't do this. And this was about a 5 percentage point increase. We went from 75% generic prescribing to 80. So a little bit of a move, but not enough. And this was kind of before the nudge unit started. So we were working with the health system to think about how could we make this more impactful? How could we move the needle further? And so what we did is we used some evidence from organ donor consent rates. So this is Western European countries. The countries on the left are like the United States, where you have to go to the DMV or sign up to be an organ donor. And you can see the rates of organ donor consent are low, 5 to 25%. The countries on the right are opt-out, where by default you're an organ donor, but you can go to the DMV or fill out paperwork to say you don't want to donate your organs. Now, the choice is preserved. You can be an organ donor or not. It's just what is the path of least resistance and what do you have to do work to set up. And so you can see here, this is almost 99% for all of these countries. So how is this rolled out in the electronic health record? So this is the confirmation page. Let's say you choose Coreg or Carvedil. It doesn't matter. This page pops up. It lists both the brand and the generic there. You confirm the dose and the frequency, and then what was added was this text box, dispense as written. Now this is a box that has been on prescription pads for decades, but never made its way over into the electronic health record. And the idea here was that if you really wanted to prescribe Coreg, the brand name prescription, then you had to check this box. And if you didn't check this box, it was going to go to the pharmacy as a generic. And so we wanted to see what happened. This is something that the health system rolled out. When I was a fellow, we had done the previous project and rolled it out health system-wide before the nudge unit actually launched. This was the top 75 most prescribed drugs. You can see that we are all over the map here. Some of these we do very well. We're already at 100%. Some of these we do very poorly. We're in the 30 or 40%. But if you follow any line from left to right, we're generally about the same. And you can go back years in time and it's about the same. So in November 2014, this rolled out. And this is what happened. The generic prescribing rate skyrocketed from 75% to 99%. Penn Medicine went from being the worst generic prescriber in the region to being the best and has stayed that way for over 2.5 years. This has saved, we've done some conservative cost analyses on this, and it's saved about $32 million of unnecessary spending by shifting patients, even if you account for patients who are converted from the brand to generic at the pharmacy. That is with the exception of one drug. One drug did not go to 99%. Does anybody have a guess as to which drug did not go to 99%? Statins? Nope, statins went to 99%. Nope, not Viagra. Yeah, we only looked at drugs for which a generic was available. Keep that in mind. So it was actually Synthroid or levothyroxine. And so the reason is that this is one of the rare exceptions where the brand and the generic are different, which is that if you have 100 micrograms of Synthroid and 100 micrograms of levothyroxine, they're manufactured by different companies, and the contents of the tablet or gel tab that they're built in actually affects people's metabolism differently. So if you're well tolerated and titrated on the brand and you switch to the generic, your body may react differently and you may need to be retitrated and get TSH every 6 weeks, get a different dose of that. And so you can see that clinicians are opting out. So we're not tricking people, right? They're actually opting out. Now, these are all new prescriptions. We're not taking people who are on brand name and switching them. These are people who are coming into the health system. So 20% of the time, the clinicians are opting out. And they're doing this at a steady rate over 2.5 years. If we were tricking people, then what you might find is actually first couple months is 20%, and then this dips down as clinicians realize that they're inadvertently shifting people incorrectly for this. And so this is a great example of a great nudge. Saved over $32 million over the course of 2 years just for these 75 drugs, move Penn from last to first place, and clinicians still retain autonomy to be able to opt out when they want to. Questions on this? I saw a couple of half hands. Yeah. So I heard it. So you. Well, yeah, I think this shows that people are appropriately, so these are patients who are coming, these are new patients, right? These are new prescriptions. These are not patients that are already on Synthroid. So if they do, they go through the refill mechanism, which is different. So these might be patients who are coming from Temple, or maybe they moved from Florida here and they're already on brand name Synthroid. And that's 1 in 5 patients. These also could be patients who we just discovered they have hypothyroidism, and we're starting them on a medicine for the first time. And the question is, are we going to start them on Synthroid, or are we going to start them on levothyroxine? In the past, we would, about 40% of the time they'd be on the generic. Now it's 80% of the time. And so we think that this 1/5 is the people who are already on Synthroid. It's not that we're moving people off. Now, that doesn't mean we're not going to miss people, and some people won't be shifted. But there was already a nudge in the other direction, which was that we were putting tons of people on expensive brand name drugs instead of the cheaper equivalent generic drugs. No, I think the point is these people, these 20% were already on the brand name Synthroid, and for them they may be hard to titrate. It's not that it's better, it's that it's metabolized different. So if I take 100 grams of Synthroid, I don't know how many micrograms of levothyroxine is going to be right for every person here. It's actually going to be different depending on your body. And so you could spend 3 or 4 months trying to titrate that, but most clinicians will just leave them on the brand name.
He raises a certain point, though, and that is that isn't there an educational problem relating to informing clinicians that in many instances the generic is as good as the brand?
Oh yeah, Penn spent years educating clinicians. Like they mentioned, they had grand rounds around this. They went to all the outliers, the people who prescribed a lot of brand names inappropriately, and sat down with them and told them, hey, this is a priority. Every one of the divisions set up a quality improvement initiative of the year, and there was all kinds of education. And that did not move the needle. We stayed at 75% with the education. I think education is critical. You have to have education. But the point here is education is often not enough to move people, because the workflow is nudging people in the wrong direction. It's so hard to overcome the fact that you've got to type in 15 medications in 2 minutes, and you're not going to take your time to go down to the end of the list. You're just going to keep blowing through this. And so I'm going to move forward. I know we're a little behind here. We started late, so I want to get to some more examples. So the next one is from the opioid crisis. We know that the size of the first prescription, if someone comes in, they've never been on an opioid, the size of the first prescription is directly linked to whether or not they're going to be taking opioids 1 and 3 years from now. Someone comes in the ED with an ankle sprain, probably shouldn't be getting opioids at all, but if they do, the guidelines recommend 3 to 5 days of opioid tablets, no further. And if you were to get that, the CDC data shows that about 5 to 7% of people would still be taking this a couple years out. The challenge is that most electronic health records are defaulted to 30 days of tablets. If you come into for a refill of your blood pressure medicines, you get 30 days, or your statin 30 days. And the same thing was true of opioids. They were set to 30 tablets. So Kit Delgado, an emergency medicine physician, recognized this, and we worked with him to change this. So what happened here is before the intervention, only 21% of people were receiving guideline concordant opioid prescribing, which is 10 tablets or less, about 3 to 5 days of opioids. And what they did was they implemented basically a 15-second change, which is they went into the admin portal and changed 30 to 10. That's literally all it took. And this doubled the proportion of people that were getting guideline concordant opioid prescribing. And this is probably actually an underestimate, because there's been a tightening on opioid prescribing, so a lot of these patients were shifted off to Tylenol and ibuprofen and so on. And so you can see that a really quick change doubled this proportion really quickly. So those are really, really quick one-off decisions, brand versus generic, 30 tablets or 10 tablets. Many decisions are much more complex. They involve multiple stakeholders or pathways that have to be implemented. So here's an example of that. This is in cardiac rehab referral. We know that cardiac rehab, which is an evidence-based pathway after someone has an ischemic event like a heart attack or stroke, can reduce mortality or readmissions by up to 30%. This involves exercise and adherence and nutrition guidance. But at Penn, only 15% of people who came into the hospital with a heart attack were discharged and told they should go to cardiac rehab. And this is really a national problem. 1 in 4 hospitals refers less than 20% of their patients to cardiac rehab. Now, when you ask a cardiologist about this, they typically say this is like fluoride in the water. It's good for every patient. There's really no harm. This is supervised exercise and nutrition guidance. Then we say, why wouldn't you offer this to every patient who has a heart attack? And the reason we discovered after meeting with everyone and observing what they do is that this is a manual opt-in process. The cardiologist on rounds is responsible for identifying who should be referred for cardiac rehab. Up until this year, it was a paper form with like 15 fields on it that involved patient name, MRN, date of birth, things that the clinician's got to fill out on rounds, and then that form has to be faxed. And then from a patient side, it's manual. And up until this year, Penn didn't have its own cardiac rehab program. So patients had to figure out in the community what cardiac rehab program has a spot available and is accepted by their insurance. And they had to go out and call their insurance and the cardiac rehab program to do that. And so we work with, so this was led by Shriyad Sumali, Neil Choksi, and Elizabeth Jolly in the cardiovascular division, and work with them to redesign this as an opt-out pathway by leveraging some technology. So turns out we can identify who had a heart attack just by some simple things in the electronic health record. Were you in the cath lab? Did you have a stent placed? Are you on certain medications? And then we can, with some testing, we can automate that and then link it to Curator, our secure text messaging platform. So now, every day at 8 a.m., the care manager on rounds gets a text message with the names and locations of the 3 to 4 patients who should be referred. We then work with cardiologists to restructure the rounding and discharge process so that for those patients, the question was asked, should this patient be referred to cardiac rehab? And it turns out we can get a lot of this information from the electronic health record, like name, date of birth. And so we template the form and the cardiologist just has to sign. Now this is moving to electronic to make it even one step easier. They just have to sign electronically. Right now it's still paper, but it's soon moving electronic. And then the care managers close the loop. Just like if a patient was being referred to SNF, a skilled nursing facility, you would meet with them and walk through their options. The care managers are now coming to the patients with a vetted list of cardiac rehab centers with availability near the patient's home that's covered by their insurance and saying which one of these do you want to learn more about. And then the care manager calls the cardiac rehab center on the day the patient's discharged to let them know the patient's coming, and then calls 30 days later to see if the patient actually showed up. So here's what happened. This is the cardiac rehab referral rate for the 3 hospitals here in Philadelphia, Hupp, Pennsylvania, and Presby. You can see it's dismal. 0 to 15% of patients who had a heart attack or ischemic event are referred for cardiac rehab when they're discharged from the hospital. The top line is Hupp. This is the intervention site. We spent 3 months experimenting. How do we identify the right patients? How do we understand the process? Who should we text? Should we text the cardiologist, or should we text the care manager or someone else? And then how do we restructure rounds? And you can see that there was a little bit of a change. This is the educational boost. We met with every cardiologist on the team, and they realized that this is important. They realized that we're watching them. It's kind of, we call this the awareness effect, but still far from where we want to go. And so in 2017, we implemented this pathway at Hupp, and you can see that the cardiac rehab program referral rate skyrocketed to about 80%. This is about 6 months of follow-up. We now have this all the way until last month, and it's been sustained at 80 to 85% since then. What's interesting, so we had a big effect, is 47 percentage point increase compared to the control arm. What's interesting is the control sites, what happened at the control sites. In the first quarter, nothing happened. These are essentially flat. But then at the end of the first quarter, at their divisional or departmental meetings, when these hospitals are hearing about the great success that we had over here at Hupp and realize that they're being watched. And so you get essentially another awareness effect. This mirrors the impact we get here. But they've essentially been stuck at 25 to 30% since then. And so we're now working with those health systems to try to roll them out at those as well.
Excuse me, the big question there is not how many you got to rehab, but was that increased use of rehab facilities beneficial?
Yes, great. So you have a good segue to the next point that I was going to make. So many people asked, so one is this is people that are referred. So the next question is how many people actually showed up? So before the intervention, a third of people were going. So a third of 15% is 5%. After the intervention, 55% of people were showing up. So 55% of 85 is about 40. So an 8-fold increase in the people that actually go to cardiac rehab. Now, the next question beyond that is, does it actually improve events? Now, so we have a lot of evidence to show that it does, but we're going to be we're working with Independence Blue Cross to track these patients to see if they had another claim for an ischemic event in the year following their discharge. So we're working on getting that data. But we do know there was an 8-fold increase in attendance, in addition to this increase in referral. Other questions? Okay, the next type of, those are all defaults, either for a single transaction or for a pathway. Now I'm going to talk about another type of nudge, which is active choice. The idea here, and I'm going to talk specifically around flu vaccination, in which 60% of Americans don't get vaccinated each year. The idea here is this is an alternative to waiting to someone to make a decision. You actually can't move forward in your process before you say yes or no. It has some benefits, which are that you can prompt someone at the time when it might be important, like when the patient's in the room with you. You can increase the saliency of the advantages or disadvantages of saying yes or no, and then you can just make it easy to say yes. It's not a simple reminder. You can link it to the actual order, or you can link it to a complex protocol or pathway so that they just say yes and move on. Now, I already showed you the example from airlines, how they make you answer this question and that causes people to buy trip insurance. Here's another example. This is from Domino's. So you're using their app. They know that you're hungry, right? You're ordering pizza. You go to hit pay, and it checks to see what's in your cart. And it realizes that you haven't ordered dessert. And so it asks you, would you like to add the chocolate lava crunch cake? And to make it really tempting, they show you the chocolate oozing out of the chocolate lava crunch cake. And so the idea here is people start to get this anticipated regret. And this is the anticipation of finishing your pizza and regretting that you didn't order dessert. And so the behavioral the behavior that this drives is regret aversion. So you do things to avoid that regret, which means you order the chocolate lava crunch cake. Now, Domino's has been very vocal about using behavioral science to try to nudge people to do this. Their stock price has quadrupled in the last few years, and now they've actually changed this to a big green yes, and the only way to say no is to click this X, which doesn't appear for 5 seconds. You have to look at this picture. Now, if you have already I've tried all these different permutations. If you added the chocolate lava crunch cake, it'll ask you to order breadsticks. If you've added breadsticks, it'll ask you to order soda. The very last thing it will ask you to add is a salad. But at some point, they will nudge you towards a healthy option. So how does this work in Epic? Not as pretty as Domino's, but this is the nudge that was implemented in 2012. A practice on 3701 Market one floor decided that they were going to implement this and basically asked, this patient's due for a flu shot. It checks to make sure they haven't been vaccinated already and they're not allergic. And it asked, in this case, the medical assistant and the clinician to decide whether to accept or reject this order for the flu vaccine. So back in 2014, the health system was trying to decide, should we expand this approach to other clinics? And so they went to this one practice in the entire health system, they implemented this and said, what do you think? And they said, our vaccination rate's gone up. You should expand this to other clinics. So then they went to the other clinics around that clinic and they said, what do you guys think about this? And they said, well, our vaccination rate's also going up. How do you know that it was this alert that caused the vaccination rate to go up? And this is a central challenge with these types of things. Many of these, many governance and IT folks are making changes all the time, but not always systematically testing to see what worked. And so this was an opportunity for us to kind of step in and see whether or not this worked. When you go to ask clinicians at that practice about this, they say, there's way too many alerts. We're getting alert fatigue. You can't bombard us. Actually, there were 15 of these, not just for flu vaccine, but 14 other things, lipids, A1C, colon cancer screening, breast cancer screening. So we did an evaluation. We compared the blue, the intervention practice, to the orange, the control. This is 2 years before the intervention. You can see after the intervention, they were both right. The flu vaccine did go up, and that was because it was the vaccination rate did go up, and that was because it was a bad flu season. But it went up by more in the intervention practice, about 6.5 percentage points, or a 37% relative increase. So it did work. Obviously, it had some downsides, which were alert fatigue. And so what we recommended to the health system was you should expand this, but that you should make some changes, which are that you should reduce the number of notifications. Each practice should pick their top 3 to 5, not 15 things that physicians can be alerted about. And right now, you're alerting both medical assistants and clinicians. And so what happens is a patient walks in, medical assistant checks their blood pressure and vitals, asks the patient if they want the flu vaccine, enters the order. A physician opens the chart, and before they can see if the MAs enter the order, they get asked, do you want to enter the order? So the clinician enters the order, and now they've got 2 orders, and now the clinician has to remove it. It was a lot of redundancy built in there. So we said, let's not bombard clinicians with these alerts. Let's just use the medical assistants to prime the patients going in, so that patients who say, yes, I want the flu vaccine, the clinician can just sign the order. The patient's already consented to that. But patients who don't want it, the clinician can talk to them. As opposed to focusing on dealing with alerts, they can spend that time talking to patients about why they don't want the flu vaccine and seeing if they can educate them or have a discussion around there. And so we work with Rebecca Kim, who was a medical student at the time. She's now a first-year primary care resident, to evaluate this second approach. This is expanded to 3 clinics, 2 in Philadelphia, 1 in Radnor. We compared those 3 clinics to the 8 control clinics that didn't do it. The first thing you'll notice is the flu vaccination rate is already better. We're around 50%. Over here, we were like in the 20s. So it's easier to go from 20 to 25 than to go from 50 to 55. So that's one thing to take into account. It's already harder because we're doing better, which overall is good. But despite that, there was a huge increase, about a 9.5 percentage point increase here compared to the control practices. And when we talked to clinicians, everyone loved this because they were not getting bombarded with alerts anymore, and they could really focus on this. If this was expanded to every practice at Penn Medicine, 7,000 more people would be vaccinated a year than are currently being vaccinated. So this is great. We're up to 60% in these clinics. We're here there. We obviously think we should expand this, and this has been expanded to family medicine and other practices. We started looking around the data to see what else could we do to try to improve the vaccination rate. And we found an interesting trend, which was that at almost every practice at Penn Medicine, if you were a patient and you came in to see your doctor at 8 or 9 o'clock, the chances that you got the flu vaccine was 45%. But if you come in to see your doctor at 3 or 4 o'clock, it's almost down to 30%. So 50% reduction just based on the time of day. And this is a steady decline that goes up after lunch. And we see this in almost every practice, and we can do all kinds of modeling to adjust for differences in patients or differences in physicians, and we still see this downward trend. So what do we think is going on here? There's essentially, there are probably multiple things driving this: patient factors, staffing factors, physician factors. But two things that we've honed in on are that as clinicians are going through their morning, at 8 o'clock you're seeing your first patient. You're generally on time. You've got maybe your full 15 minutes, but at 11 o'clock you might realize it's 11:30 and you've got 6 patients to see. And so you're rushing through those visits. You've got less time. We do see an increase after lunch when people generally start with a new panel of patients. The second is this concept of decision fatigue, which is as people make decisions, regardless of what area it's in, they start to get tired. So you can imagine that as you see 4 patients and you've given your spiel, your 5-minute spiel about why you should get vaccinated, how it protects you and others and so on, and all 4 patients say no. Despite you giving them their spiel, then you go to their 5th patient and you might be less likely to go through that whole spiel again because so many patients have said no over time. So as more patients say no, you're less likely to even go through the effort of doing that. We did look to see how the nudge affected this. So this is the control practice, no change before and after. There was no nudge there. Here you can see that there's a general increase and that by 4 o'clock in the practices after the nudge, we're doing about as well as we were at 8 o'clock before the nudge. But this is still downtrending. We still have these challenges with decision fatigue and so on. So we're working on ways to try to work with practices to be able to address that. This is something that would have never been even realized without diving into data and systematically looking at this. We found this same trend in colon cancer screening, breast cancer screening, a lot of other things that we do in primary care practices.
In the clinical laboratory, 40 years ago, they noticed that because manual transcription was being used to transcribe all the results in the lab, that the manual errors of transcription in the afternoon always increased.
Yeah.
And that well documented in lots of publications.
Yeah, there's all kinds of, there are, judges give different sentences later in the day than they do at the beginning of the day. There's evidence on that. There's evidence in healthcare on hand washing. People wash their hands less later in a shift. And there's also evidence in primary care practices about inappropriate antibiotic prescribing. At the end of the shift, you tend to just give more inappropriate antibiotics to patients than you do at the beginning of the shift. This is all this concept of decision fatigue. So I'm going to move into population health in the last couple of minutes. So all of these things I've talked about are individual discussions with patients: brands versus generics, size of an opioid, flu vaccination, cardiac rehab referral. What about thinking about ways to think about populations of patients? How can we take nudges and actually deploy them so that we can make larger impacts more quickly? This was actually a challenge that came to us from the executive leadership, which was that 40,000 patients at Penn meet national guidelines for statin therapy, and we know statins are really effective at reducing ischemic events and reducing mortality from cardiovascular events, but only half have ever been prescribed a statin. Now, some of these patients may decline, but we think that many of these cases are cases where it's just never been discussed, or there's an opportunity here to nudge clinicians to have that discussion with patients. So what we wanted to try to do was test a new model of care for prescribing statins, and this was, most statins are prescribed at a clinic visit with a patient in front of them. So we wanted to see if we could provide physicians with a list of their patients who should be on statins, and if they would be willing to bulk order outside of the visit. And then we would communicate how this worked with the patient. Now, the health system asked us to do this at a time when there was an Epic freeze because they were turning on Epic in the inpatient setting. And so what we did was we did this all outside of Epic, but we got IT to agree that if we could demonstrate some valuable insights, that they would work with us to implement this once the Epic freeze was over in the primary care practices. So we did this as a randomized controlled trial. This was done with, at the time, someone who was taking a year off after college, Greg Kurtzman. He's now a second-year med student. Essentially did all this work. We took 96 primary care physicians randomly from the health system from 32 practices. That represented over 4,700 patients among those 96 primary care physicians who met evidence-based guidelines for a statin but weren't on it. And we took away anyone with an allergy or elevated liver enzymes or elevated creatinine just to be conservative. And we randomized the physicians and their patients to one of 3 arms. Usual care, which is do nothing. We just watch them for 2 months and see what happens. An active choice dashboard that I'll show you in a second, where we give them a list of their patients and we allow them to actually choose and make decisions for statin prescribing. Or, because we know that these types of dashboards exist already and clinicians just don't use them often, we combine that list with a nudge, which is a peer comparison feedback. So we tell clinicians how they do compared to their peers in statin prescribing. And we want to avoid regression to the mean, which is if we tell you you're doing better than average, many people will say, oh, that's great, move on, or they'll slack off. And so we did this in a tiered approach. If you're below the average, we told you how compared to the median. If you're above the median, we told you how you compare to the top performers. So moving 90% of people to do better. And if you were already a top performer, you were commended or recognized as a top performer. Now, I mentioned this wasn't done in Epic because we didn't have the ability to do that. So we essentially did this with the man behind the curtain, doing all this stuff manually. So we pulled data from the electronic health record. We manually sent emails to the PCPs with a link to the secure website. The website was built by developers at the Innovation Center. You could log in with your UPHS credentials, but it was outside of Epic, so it was a new system. The PCP then makes orders. This is essentially a HIPAA compliance survey. The research coordinator then looks to see if they place orders, pens them in Epic, and then sends the doctor a note letting them know that the orders are ready to sign. And then once the clinician signs them, sends the patient a letter explaining what just happened. Dr. So-and-so was reviewing your chart, recognized you meet guidelines for a statin, here are the risks and benefits, here's a number to call if you have questions or want to discuss this, otherwise please pick up the prescription at this pharmacy location within the next 7 days, and so on. So this is the website. The email was much shorter, but the website, if you wanted to understand which guidelines we use or how we identify these people, this is a detailed description. Now below this, you would have a list of all your patients. Some clinicians had 10, some clinicians had over 200. The average was about 45. And what you could do is you could press this button, set all to atorvastatin 20, and all of your patients would be put on the starting dose of atorvastatin. Or what most clinicians did is they went individually through each patient. And we provided information like the ASCVD risk score, your last cholesterol measures, any risk factors like smoking or MI, and then any things you might be concerned about like liver enzymes, and also a bridge to the electronic health record if you wanted to look them up. And then we used this active choice framework, which was prescribe atorvastatin 20, prescribe atorvastatin at another dose. Maybe you have a different statin, which you click on this and the drop downs for the options come out, or don't prescribe, and then a drop-down with 8 things pops under, or a text box, and you can say why you didn't prescribe it. And the idea was to try to get clinicians to fill this out. Now we know clinicians could just ignore this. Clinicians ignore the emails and dashboards all the time. They never log in. And so that's why we combined this with a one-time email, which tells you how you compare to your peers. So this is what happened in the control arm where we did nothing. Only 2.6% of patients got prescribed a statin. Now this is not surprising, right? We know clinicians only prescribe it about half the time, but we know that you have to actually have a visit. And in 2 months, many of these patients didn't come in for a visit. And so very little statin prescribing. If we gave people a dashboard, this doubled to 6.7%, but was not statistically different than not doing anything at all. The most impactful is if we combine the dashboard with the nudge. This tripled statin prescribing from 2.5% to 8%. And this was like a one-time message, basically. We just sent the email and that's it. Now, compared to the others, this is a much smaller effect, about 6 percentage points, but we had a lot of challenges because this was done outside of Epic, and so a lot of manual things. And so we learned from clinicians that fitting this better within their workflow, namely within Epic, would allow this to be more effective, and then giving them options for clinic-based versus outside of clinic-based prescribing. So since then, we've gotten a large NIH grant and are rolling this out. We've got an agreement from 110 primary care practices across the Penn Medicine Network to roll this out, a slightly upgraded or modified version of this as a step wedge cluster randomized trial to be able to roll this throughout the entire Penn Medicine network. So I'm almost out of time. I have a couple of examples of patient behaviors. Should I stop here, or do you want me to talk for a minute on this? I don't know what. If people have to go, I can stop here. Continue. Okay, I'll try to do this in 3 minutes, so I'll go quickly, but I'll stay after for questions. So we know that motivating patient behavior is important: eating, diet, exercise, medications. This is just some other, we've gotten a lot of press around this in the past. So we did a study with faculty and staff at Penn. We randomly assigned them, we wanted them to be physically active, and so we asked them to download an app and walk 7,000 steps a day, and then we randomly assigned them to control, which is just get a text message every day on whether or not you walk 7,000 steps, or one of 3 incentives, all with the same value but framed differently. And so in the standard approach, which most insurance companies are based off of, standard economics, you get $1.40 every day you walk 7,000 steps. And so at the end of the month, you would get up to $42. And this was a 3-month trial, so you get over $120 if you walked 7,000 steps every day. We had a lottery arm with a 1 in 5 chance of winning $5 or a 1 in 100 chance of winning $50, and you just picked a lotto number, and a lotto number was drawn every day. Mathematically, that comes out to $1.40 a day. Or a loss framed arm. We put $42 in a virtual account, and we take $1.40 away every day. Now, what's important to take account is that From an accounting perspective, it doesn't matter which arm you're in. If you met your goal about 10 times, you're going to get $14 at the end of the month. We actually paid people the same way. Everyone got a check in the mail at the end of each month with their accumulated earnings. So nobody was paid differently. But from a psychological perspective, there's a huge difference, because as much as people like to get $1.40 per day, they really hate to lose $1.40 per day. So this is what happened. The control arm met their goal 30% of the time. The gain arm 35, but statistically no different than not paying them at all. Lottery arm a little bit better, but we didn't have enough power to detect a difference. The most effective arm was the loss frame arm, 50% relative increase. 45% of the time people met their goal. Now keep in mind, all we did was change the upfront messaging. They were paid the same way and the same amount, but yet we get a dramatic increase in activity. So this was a overweight and obese sample of probably a more educated, and because they're faculty and staff and healthy people. We wanted to try this in patients who are older with heart disease. And so this was a study led by Neil Choksi in the cardiovascular division, where we enrolled patients from 4 Penn hospitals. We did this all remotely. They can't have already been in cardiac rehab or not have a smartphone. We did a trial over 24 weeks, which is twice the length of cardiac rehab, and we enrolled people from homes. We identified people, reached out to them, and if they wanted to sign up, they could go online, and once they filled out the surveys, we would mail them a wearable device. This wearable tracks your step, doesn't have your step count like a normal one was. It has goal achievement, so these lights light up as you reach your goal. It's waterproof, and it doesn't require charging for 6 months. So no reason to take it off. Like your typical wearable, you have to take it off when you go in the shower, or you have to charge it every day or every couple of days. So we told patients it also tracks sleep. So we told patients wear this continuously for 6 months, because every time you take it off is another opportunity not to put it back on. We had people this time establish a baseline. So we told everyone to strive for personalized goals, not just 7,000 for everyone. And then we randomized people. Here's how it worked. In the control arm, they just got the wearable. This is what many programs, insurance companies are doing, workplace wellness programs, just giving people wearables and seeing if it can get them more active. Or we gave them a tailored program with personalized goal setting, where we slowly ramp you up over 8 weeks and then have you stay there for the subsequent 16 weeks. And we combine that with loss-framed incentives, this time $2 a day. So we put $14 in an account every week, and you lose $2 each day you don't meet your goal. And the reason we did it weekly here was that people could have a bad week, and they would get something we called the fresh start effect, which is a whole new week. If you had a bad week, we sync this on, so you always start on Monday, and so you can say, hey, this is a new week. I'm going to try to change and really achieve my goals this week. So this is what happened in the control arm. This is the change in steps from baseline. This is time. You can see in the first couple of weeks, the novelty effect, people get a new wearable. They increase their step count by about 500 steps. But over the course of 6 months, this essentially goes to 0, even here falling below average. Now, if we combine the wearable with this behavioral economic program, you can see that it's much different. People go up to about 2,000 steps during the ramp up. This drops in the maintenance phase, but remains above 1,250. And then when we turn the incentives off, it remains above 1,000. You can see that this decline is about the same as this decline. So on average, these folks who had heart attacks in the subsequent 6 months after their heart attack walked about 100 miles more than these folks, at a cost of about $104 by combining this program. So how can we do this without money? That's financial incentives. We've been doing this with social incentives and gamification. Gamification is used really widely. We had a study with Humana, who has deployed a gamification platform to 5 million beneficiaries, but they do this using a standard economic approach. It's only used by about 2% of their members. And so we use that to help us think about how we might design a better approach. We had a med student, Victor Cotton, download the top 50 health and fitness apps in the App Store and look to see which ones use gamification, and if they did they use standard economic design or behavioral economic design? And he also went through and talked about what are the types of features of gamification. So goals, social influences, challenges were the top, actually much higher than points and levels, which people tend to think about. We found 64% of the 50 top apps in the App Store had gamification. That's 2/3 of them. But none use behavioral economics. They're all built on standard economics, this idea that you have to do a bunch of things, then you get points. If you get enough points, you move up levels. So we partnered with the Framingham Heart Study, the longest cohort of, one of the longest cohorts of families in the United States that's to run a clinical trial to test this. And in doing this, I learned 2 things working with Framingham, which one was they've never done a clinical trial, so this is the first and still the only clinical trial they've ever done. The second is they've never paid the members of Framingham. And they come in for their assessments every 6 months because they're in Framingham and it's part of the culture. And so they didn't want us to pay the members of Framingham to be in this study, because then they were worried that they'd want to be paid for doing things they're already doing. So it was a good way for us to do this. We had them enroll their entire family as opposed to enrolling themselves. You establish a baseline and you select a goal. We use some insights from taxi cab companies, which is they moved from having you type in a tip to saying $2, $3, or $4 or enter your own tip, and that actually increases tips by about 22% because you just click 2 instead of typing in $1.50 if the ride was $8.50. And so here we say, do you want to increase your step count by 33, 40, or 50%, or choose your own goal as long as it's 1,500 steps or higher. They then sign a pre-commitment contract. We know that people who commit to their goal are more likely to stick with it, and every time they log into the platform, they see their signature on that contract. You then get endowed with points. Instead of a normal approach, which is that you do something, you get points, we give you 70 points up front every week, 10 for each one of the day, and you could lose points if you don't meet your goal. Now, to really bake in the social incentive, we randomly pick someone from your family every day, and that person represents the team. So if you meet your goal, great, keep your points, but if you don't, you can imagine if your entire family got a text message that said that you were selected to represent the family and you didn't meet your step goal, so the whole family loses 10 points. Most of these families live together, and so they would probably take you for a walk when you got home that day. And then you can progress through levels, bronze, silver, gold, and platinum. If you get to the platinum level by the end, you get this coffee mug. So not really just a nominal prize here, but people got really excited about it. It has some symbolic effect. People wanted to be the best family in Framingham. They wanted to show off their coffee mugs and so on. So this is what happened. The control arm here. Now the control arm, mind you, is families who mostly live together who get a daily text message about their activity. And they still only achieve their goal 30% of the time. With the game, which essentially costs nothing except to run the platform and send the same daily text message, we get this up to about 50, as high as 60% at some point. We turn off the game and we see this goes down a little bit, but there's still a significant difference that's sustained. These family members each walk about 1 mile more per day than these over the entire course of the study. We've now partnered with Deloitte to run a national study. This is 602 people from 40 states across the country. What I just described to you, we call it collaborative social incentives. The families work together. Here we're getting overweight and obese employees to either work together, compete, or get support from a family member to test this on a national level. We're also doing a lot of what we call behavioral phenotyping. We're asking people to fill out the Big 5 personality test, tell us about their risk-taking preferences, tell us about their social support, and trying to identify, if you're an extrovert with a large social network, maybe competition is the best for you. But if you're an introvert with a small social network, maybe support would have worked better than that. And so we're trying to predict what's going to be most likely to be effective for you and then match people to that outcome. The intervention here has ended. We're in the follow-up period, so hoping to report results later this year. We've gotten a lot of press around this. This is around some similar work we're doing in diabetes. This is around the Nudge Unit in general and the Harvard Business Review and The Economist. We've since launched the Nudge Unit Symposium because we've gotten a lot of other health systems who want to build a Nudge Unit, and we did this last in September. 22 health systems from the US and Canada came to Penn here in PCAM, and we held a workshop to help them think about how they might structure their Nudge Unit, and we've since launched a Nudge Unit Collaborative, a technology-based platform to help reduce the upfront effort that you need and to be able to learn from lessons that other people have been doing. So in some cases, they can actually take the code that we've used from our flu vaccine Nudge, and they can implement it into their electronic health record, and they can get a quick win, assuming it works similarly there. So in summary, medical decision-making, as you've seen, is often suboptimal. The design of our choice environments influences our behavior significantly. In most cases, we're already being nudged, but we just aren't aware of it, and so this deserves a lot more strategic attention. And Nudge Units take a systematic approach to thinking about the best way to systematically design, implement, and test nudges to improve decisions and patient outcomes. So, thank you.